Welcome to our CCCR speaker series today. We're delighted to have Dr. Steve Marshall and Yvonne Golightly. Dr. Marshall is the director of the Injury Prevention Center at UNC and a longtime collaborator with the Thurston Arthritis Research Center. He was the principal investigator for this project that was part of our previous MCRC. Looking at biomarkers and outcomes in the military cadets in the JUMP-ACL program. And Dr. Golightly is a member of TARP as well as an associate professor with tenure in the Department of Epidemiology and also a member of the Injury Prevention Center. So we're looking forward to hearing the results, Steve. Thank you.
Thanks a lot, Lee. It's a pleasure to be here today and have an opportunity to present some of this work. For various reasons, it seems to be taking us longer than I expected to finish it up. But so I apologize. To some extent, this is still, unfortunately, a work in progress. But everything is, in a sense. And I think we're getting very close to being able to put closure on this one, which would be good. I'll start with sharing my screen. And I'm thinking everyone can see the title slide now.
We can.
Okay, great. So the overall project was called Biomechanics and Biomarkers associated with progression to OA subsequent to knee injury. And it's a great honor, real privilege to have Yvonne with me today. And feel free to chip in as we go along, Yvonne. I think you'll have to unmute and speak because I only have the one monitor at the moment, so I can't quite see everyone. So don't hesitate to talk over me. And the other thing I want to mention is if people do have a question or if there's a question in the chat, Yvonne, maybe you could interrupt me, let me know if there's any questions in the chat, because I seem to have lost that as well.
Okay, I can do that.
Thanks, sorry. It's just the same as class, isn't it? All right. So rough outline for this morning, and please, if I go past 3 or 4 hours, stop me. Talk a little bit about setting the stage, talk about the findings we have so far, and a short summary. So I think most people are familiar with the pathology of ACL injuries and other traumatic knee injuries. But this is a cutaway diagram of the knee showing the anterior cruci-ate ligament. The ACL has sort of jokingly been called the sporty part of the knee, whereas these outer line ligaments provide stability for routine tasks that the ACL and the PCL to a lesser extent allows the knee to bend and pivot, but still maintain a high level of function and stability during really vigorous tasks. A tear is obviously a partial or complete transect of the ACL. There's also sometimes a rupture injury mechanism in which the ACL just kind of goes, looks like a spent rubber band, so I'm told. It just kind of goes and loses its integrity without any obvious, transecting injury. Fortunately, if you're an athlete, this can be a very debilitating injury that can require months and months of dedicated rehab to get back, and it's very gutting and soul destroying. For non-athletes, it can sometimes be managed without a reconstruction. And the population we're going to talk about today, which is military officers, reconstruction would be the standard. So almost any ACL tear in an active duty officer or any active duty personnel is going to be reconstructed. But there is the option of conservative management, non-surgical management if the person has good function, but that's not usually an option for the military people. Irrespective of whether they're reconstructed or not, the progression to osteoarthritis is inevitable and proceeds at a very similar trajectory. It doesn't matter whether it's reconstruction or not. So, very high incidences have been observed in this injury in athletic populations, including military populations. Osteoarthritis, I'm talking to the choir here, but is characterized by this narrowing of the joint space, loss of cartilage, development of osteophytes, and obviously pain, reduced knee function, swelling following exercise. So what is the linkage between these two was kind of the topic we wanted to investigate. For knee osteoarthritis, the global prevalence sits approximately around 4%, but varies a lot by country. And it's more prevalent in women than in men, even accounting for age structure differences. But this is kind of, I threw this diagram in because I think it's roughly a good look at what you typically see: very low prevalence in the 30s. Once people progress into the 40s, OA is beginning to develop and reaches 10%, roughly by age 50. And then plateaus somewhere in the 15 to 25% range, depending on various factors, during the 60s and 70s. And so what a severe injury does is to the knee, it shifts this curve to the left. So there's some famous quotes here from our colleague at Lund University, Stefan Lohmander. The ACL injury ages the knee by 30 years. And in this famous quote, these are young patients with old knees. So there's a person of that age, but their knee is essentially that age. And that's the impact of severe ACL and meniscal injuries. We've been looking and monitoring ACL reconstruction in claims data. This is an analysis of market scan data. And what we see over time, we picked this period because it was a period of a lot of research. Over this time for men, rates have more or less been sort of plateaued, a little bit trending upwards in the 13 to 17-year-olds. But for females, especially for young women, they started kind of like boys, but have tended to increase despite all the research and publicity around women's ACL injuries. Their rates have actually trended upwards over time. So our research is not translating to prevention, unfortunately. And of course, what's significant is that women are going to develop more OA, and these women are going to develop more OA earlier. So that's very concerning, particularly as until recently, lifespan was increasing. So people could be looking at, living with OA for most of their life. So Dr. Lohmander and others have tried to articulate what the pathobiological process is that links injuries and osteoarthritis. It's clear that there's a lot of variability and that those all represent potential, well, not all of them, but many of them represent potential intervention points. And he's requested that there should be more research to help us understand and help inform prevention and treatment. People have tried to diagram out what is the pathobiological processes post-trauma that leads to these changes in the knee. How, is it cartilage based? Is the cartilage failing to adapt? Is this, are early indicators of this observable with biomarkers, various types of biomarkers? I would describe all of this as very much a moving area of research at this point in time, where there is perhaps as much guesswork as there is evidence in some respects. As an epidemiologist, I'm kind of interested in lifespan questions. So I got into this because I wanted to know, does injury kind of accelerate the onset of OA that you would have eventually got anyway? Or does it actually increase the amount of OA? So does it mean that people who would not have got OA get it? Or does it just mean that you get it sooner? Or does it do a little bit of both? In other words, does it accelerate onset or does it promote onset? Those questions, I think, still remain largely unanswered. But back in the early days, Yvonne and I got a little hint that maybe the promoter mechanism was what was happening, because when we just looked at panel data for people who had lots of sports injuries and were riddled with osteoarthritis, or riddled with arthritis, namely people who used to play in the NFL, it sort of looked like they were getting it earlier, but that towards the end of their lifespan, they weren't really getting more. So this study was an opportunity to dig a little bit more into those kinds of concepts and see if we could do something that was evidence-based, to refine those sketches and curves and cartoons with boxes on them into something that would be more useful for prevention and clinical intervention. So the purpose of the study was to investigate radiographic OA, symptomology, and patient-reported outcomes in a group of military officers who did and did not have a previous history of traumatic knee injury, on average about 9 years ago. So, and we originally started following these people when they were cadets. So these cadets / officers have a high risk of injury and post-traumatic OA. They have a physically demanding occupation with lots of knee loading. They have great continuity of employment for the most part. If they're going to stay in the military, they're very incentivized to stay in for as long as possible. Once you get past 15 years, you really want to complete 20 years. And of course, they are wonderful people because they like to complete tasks, fulfill missions, and they are protocol-oriented individuals, which means they are good for research. So the original purpose of the study, or this built on a parent study called the JUMP-ACL study, where we originally had enrolled 6,500 cadets in a prospective cohort study with ACL as an endpoint. And when they were cadets, we enrolled at these 3 large military installations that are 4-year academic programs. And this cohort was 38% female. We worked hard to oversample women. In those days, the enrollment was about 13% at matriculation for females in those 3 sites. This new study built on the prospective cohort study, the previous parent study, I should say, by using a matched prospective cohort design. We have pre-existing data. We drew all of the cases and a matched group of all of the injuries, I should say, and a matched group of non-injuries. All of these people had to be in the military. It's very expensive to track down people who've separated from the military. So just in the interests of budget conservation, we limited ourselves to people who completed their 4-year undergraduate training at the military academy and then were now pursuing a career as a military officer and still in the military. And for these people, for these 171 injuries and 261 non-injuries, we did new data collection, collected questionnaire information from them, and also got radiography and some biomarkers from banked serum. So these knee injury cases, some of them occurred prior to entry into the academy, some of them occurred during the academy, and some of them occurred after the person graduated from the academy and became a military officer. So what we're interested there is if we can use those time points to kind of dig into this accelerator versus promoter concept for the pathobiology of it. And I'm going to sort of make two passes through this, and I'll stop and see if Yvonne wants to contribute as we go along. But for patient-reported outcomes, we have KOOS measures and the single item assessment that's been widely used in the Johnson County study and elsewhere. For clinical outcomes, we ask, have you ever been diagnosed by a physician with osteoarthritis? And in a subset of people whom we could get into a X-ray machine at a military installation, we were able to obtain a radiography. So I'll quickly go through the instrumentation here. I think many people are familiar with the KOOS instrument. If you're not, it's 5 scales, a total of 62 items that cover a 1-week recall period. The scales capture pain, symptomology, activities of daily living, vigorous physical activities, sports and recreation, and quality of life. This is a scale where 100 is perfect health and 0 is perfect ill health. Obviously, those are theoretical constructs, but you know, healthy people score in the 90s. And also the single item question asks about pain, aching, and swelling in the past 30 days. That's graded with a 4-point Likert scale, which traditionally is grouped into none or mild, versus this should be moderate or severe. To analyze these data, we made use of prevalence ratios, but we kind of quickly hit the limit of ratio measures and switched over to prevalence difference. And we were stratifying those measures, particularly the prevalence differences, by the timing of the cadets or the sub-participants' first injury, whether it was prior to their cadet career, during their cadet career, or after graduation while they were in the military. To give you a sense of what these people look like, we're running about 40% female, just under it. They're coming up, at the time we consented them, they were coming up to their 30th birthday. They'd originally been consented in the parent study around about age 18, 19, 20. In pretty, you know, robust individuals, an average of 78 kilos, BMI around 25. Average time in the people who've had injuries, the average time from the first injury to the follow-up point shown in this analysis was right around 9 years. So these are people who are not approaching their 30th birthday and had an ACL in their early 20s, is one way to characterize them. So let's look at KOOS and that single item. So Yvonne, before I kind of launch into the results, is there anything that I forgot to mention or any clarification that we should add?
Yeah, the only clarification that I have is about the single item question. It was for pain, aching, and stiffness.
I'm sorry, my internet faded out. Could you say that again?
For the single item, it was for pain, aching, and stiffness.
Stiffness, thank you so much. I will fix that. I had swelling, didn't I? So these are what the KOOS scores look like for the people who have never at this point had a knee injury, and they look to be very healthy. They're all A scores above 92. For the people who have previously had a knee injury, they are experiencing symptoms and they are experiencing pain. But their ADLs are not substantially impaired. So we can quantify this looking at the mean difference, thinking of the non-injury people as the referent. We have a drop of about 13 out of a potential 100. It's a very, very, that's the maximal possible range. You couldn't drop by more than 100, but that would be a horrific drop. Anyway, we have a drop of 13, which is a very substantial drop. We have a drop of 9 on pain and movement of 5 on activities of daily living. So, there's various rules of thumb for interpreting these, but it's generally sort of suggested that around 8 is going to be a clinically significant change. And smaller changes are probably still important, but definitely something bigger than 8 is going to be substantially important and noticeable for the person and should be observed by a clinician. For sports and recreation and quality of life, this is where we saw the biggest drops, and really a very large drop on quality of life. Again, these people are 30. They're very concerned about knee quality. Obviously, these people are employed in a career that involves a lot of physical function for the knee. So I suspect some of this quality of life concern, not all of it, but some of it definitely reflects the fact that their future livelihood, at least for the next 10 years, if they're going to stay all the way through to a 20-year career, that depends, on having a healthy knee. And there's a concern to some extent about having to be relegated to a desk job, which none of these people particularly enjoy. Or else being, having to leave the military early, which is, no one enjoys that after 10 years. And it also has financial implications in terms of not being able to retire at the 20-year mark. So apologize for the busyness of this slide. I just couldn't really figure out a good way to trim it down. But basically, we took those results instead of going across the top, they're now rows here. And we broke them out by the timing of the injury. So these are the people who had the earliest injuries. These are people who were injured before they were 30. So before academy, that group of 79 is people who had their first ACL or meniscal tear before they were 20 at a high school age, and they're now coming up to 30. So these are the 10-year injuries. These are more like the 5-year injuries. These are people who had their injury while they were an undergraduate, and then following matriculation. And of course, there's fewer of these because we weren't able to design the study to capture more of those people in advance. But what's interesting about this table, I think, is that things look very consistent. One of the key KOOS scales here is going to be the sport and rec activities, because that captures vigorous knee function. And, you need to bear in mind that these confidence in a PRO, you're always going to have some degree of standard deviation, some variation, and that's going to drive the confidence intervals a little bit. But, it looks a little bit like these differences are not quite as pronounced, perhaps, in the more recent injuries. But certainly the 5-year and the 10-year injuries both look to be pretty bad. And as far as you can tell, pretty bad in terms of impacting their knee function and other aspects of their life. And as far as we can tell, it doesn't seem like there's a big difference between the injuries that occurred 10 years ago and the injuries that occurred 5 to 10 years ago, at least in terms of how they're impacting these individuals. So I'll move on to that single item scale now. But the takeaway here is that certainly in terms of the changes or deficits that would seem to be clinically significant, those look kind of approximately the same across time since injury. Perhaps less pronounced for the less than 5-year injuries. This is that, we'll change this to stiffness, pain, aching or stiffness. This is the analysis of that item in the past 30 days. And as you can see, whereas 6% of people were experiencing that or endorsed that item in the no injury group, 31 endorsed it in the injury group. So this is a great little item, really, if only I could get the description of it correct, because it's although it's a little fuzzy in that people endorse it, perhaps over-endorse it, but it's very, it may not be perfectly sensitive, but it's very specific. So it certainly identifies a 5-fold increase in the injured people. This just pulls that same item apart as the prevalence difference. As I say, we kind of converted to prevalence differences during this analysis. And so that prevalence difference represents the increase from 6% to 31%. And so what you can see is based on the epoch of injury, more than 10, 5 to 10 within the past 5, about the same percentage are endorsing that item. So again, there, people are feeling some changes, noticing some changes pretty soon after injury. So I'll just wrap up the patient-reported outcomes here in kind of a summary, and then I'll ask Yvonne if she wants to comment additionally. But as this cohort, and these are people that I've been around since they were since they graduated from high school. As they approach age 30, which is the midpoint of a 20-year career as a military officer, they're experiencing pain and symptoms. They've got substantially decreased function for vigorous physical knee function, knee activity. They're noting reductions in quality of life related to the knee. Their activities of daily living look good on the KOOS for the most part. And these are questions that are relatively low energy sort of tasks, like transfers between getting out of bed, getting out of an armchair, moving around your apartment, cleaning activities, getting in and out of a bathtub. So for those low energy or less vigorous tasks, they seem to be in much better shape. It sort of seems like the historical injuries and the more recent injuries are having similar effects for those people. And that's kind of consistent with our notion of an accelerator mechanism for injury rather than a promoter mechanism. Yvonne, I'm going to transition into clinical outcomes, and most of that is radiography. But just before I go there, any comments or thoughts?
Yeah, so we just got a question in the chat from Richard about did most, if not all, injured cadets have surgical repair of ACL? And I believe that is correct. From what I remember reading a number as high as 97%. Does that sound right to you, Steve?
It's right around 97%, yeah. There's a small number that are not reconstructed. But they're really very, very unusual. The military likes to repair things, and medicine is no different. So unfortunately, we don't have the ability to see whether these changes will be different depending on whether they had surgical reconstruction, or were conservatively managed. So one of the limitations of this cohort. It was an interesting period of my career to try and make sure that we had complete capture of all of these injuries. We really had a lot of surveillance, very active surveillance through monitoring the OR logs, but also through contact with the athletic trainers and other personnel, because these people do go to other places over the summer. There was always concern about losing one that happened over the summer. And we definitely, I think, caught some that occurred over the summer and came back. I think we have as close to a complete enumeration as is humanly possible, but there was a lot of intensive monitoring of the cohort to try and make sure we registered all of those injuries. So, as I say, most of the clinical outcomes is going to be radiography, but this is sort of I guess, a bridge between PROs and clinical. It's the self-report of whether they have been diagnosed as a physician with osteoarthritis. And a relatively small number of those at this point, only 12, but the overwhelming majority of them were in the knee injury group. And so a 16 times greater prevalence for people who've had a knee injury. But, you know, I don't know really what that means as an interpretable number. It's really 11 versus 1 because these are relatively small numbers. So we did try to verify those diagnoses in the medical records. To try to see how the self-reported data compared to radiographs, we did try to get as many of these people into a military radiography suite. It's not possible to send them to anywhere off base. We had a lot of, Mary Alice did an amazing amount of work on this, both in terms of working with the participants and working with the radiology techs. We had people who drove to other installations in order to have their knee x-rays done. We had people who were would let us know when they were coming back from a deployment and what installation they were going to be stationed at next, so that we could plan ahead and train the techs at that installation. Quickly became clear that the knee positioning frame that was sort of the ORSI standard was never going to be combat ready. It was not going to survive well in a military environment. And so we custom built these plexiglass frames that were a lot more robust. They're knee positioning frames in which you position your quads against the frame in a flexed stance, and with a fixed distance apart and fixed orientation of the feet, in order to standardize, get the joint open and get a nice view on the inside of that. An ideal study would have been able to customize the interval, the amount of flexion to the anatomy of the person. We weren't able to do that. We just went with 5, 10, and 15 and gave Dr. Renner the choice of selecting whichever view he felt was best for him. And he, by and large, took the 10. All the radiographs were read by Dr. Renner. Training the techs and acquiring the images required Mary Alice to put some miles on the study clock. So Mary Alice personally traveled to almost all of these installations. She did not have to go to Germany, but she did have to go to Hawaii. Particularly grueling trip, but fortunately she was able to do it. This is a list of all the places that were visited or closely worked with. We had the original idea that we could train these people long distance, but we just couldn't, research is not their predominant activity. So actually going on site was the thing to do, to make sure that they got it right and also got it done. Yvonne has been analyzing this data or leading the analysis of this data, and she pointed out to me, and I'm very grateful for this, the opportunity to analyze it at the level of the knee rather than at the level of the individual, accounting for the within subject, the clustering due to 2 knees being on the same person. These people are much smaller in number just because it was impossible to get everyone into a radiology suite. So we have this for 260 individuals, 117 injured and 143 non-injured. You know, the non-injured people were selected at the same installation as the injured people because we couldn't afford the time and effort of standing up an installation that didn't have injuries. I mean, doing training at installation that didn't have injuries. They look very similar to the previous subjects. Some interesting things about these people, over 1/5 of them have bilateral knee injuries at 9 years following their first knee injury, which is kind of shocking. 9% of the overall people have progressed to radiographic OA, which is quite a high number, 23 out of 260. Remember, they're not, on average, they're not yet 30. And of those, 10 of those 23 also had symptomatic OA as reported by that single item measure, pain, aching, or stiffness. All of the people who endorsed the symptomatic item had KL grade greater than 2. Among all the people with KL grade greater than 2, 10 of them had symptomatic. I think that's kind of saying the same thing a couple of different ways. Radiographic OA at the level of the individual patient looks very similar to that single item question. There's a about a 60, it's 19% versus 1%. This is the analysis that was done at the level of the knee. So it's a much more refined analysis because it utilizes all of the knees. And so unlike the previous slide, which was at the level of the individual person. Of course, it's a person who gets OA. So they're both valid analyses. So, in terms of KL grade, what we see here is all of these 2s and a couple of 3s are almost all of them in the injured group, 1, 2 in the non-injured group, and a increase in the injured group of 16% in terms of the prevalence of radiographic OA. So, very, very clear indications of progression. This is the osteophyte and joint space narrowing data. These results, there are people who are far more knowledgeable than me in the interpretation of this, but as I read it, these results mostly accrue from early formation of, or post-traumatic formation of osteophytes. However, there certainly is some joint space narrowing occurring in these people as well. So a prevalence difference of +30 for any osteophytes and +17 for observable narrowing of the joint space. And obviously we're interested to break that out by how long since their first major knee injury. And similar to the patient-reported measures, things look a little bit worse for the people who were injured during the academy. That's the period in which we really had very intensive ascertainment of injuries. So the fact that things are a little bit smaller over here may represent some dilution or some mixing of things that didn't quite reach our criteria for an injury. But once again, everything's elevated. It doesn't matter whether it was 10 years ago or within the past 5 years. These indicators are going up, and they may not be quite as up in the more recent injuries, but they're definitely on the course we suspect to track from 15 to 30 in the next 5 years. So, bearing in mind that some of these are relatively recent injuries, I would say once you get past 5 years, there isn't a lot of evidence of increasing onset of radiographic OA. However, it may be getting worse in these older injuries. So just a summary on the clinical outcomes, and then I think we can probably wrap up and transition into Q&A. By age 30, midpoint of their military career as an officer and cadet, about 1 in 6 of the people with knee injuries have progressed to radiographic OA. It's quite a high rate. Very recent injuries look a little bit different, but as long as you're beyond 5 years post-injury, your profile looks approximately the same. So, this is what I do at 5 o'clock in the morning when I wake up early, is I sketch out, what is going on, what's the underlying biology, what would it look like if I could follow these people to the end of time without any competing other causes of disease, or things that would they eventually all reach the same place in terms of OA? And I have some of them just started down that trajectory sooner because of the injury. I suspect that's what's going on here, but a lot more research needs to happen before that can be confirmed. Some things about the study. Obviously, it's a very intensive protocol. They have to go on site to do these trainings, but I think that's what it takes to acquire these images. But that was something we hadn't necessarily bargained on, but very fortunate to have Mary Alice, who was going to get it done no matter what. A big limitation of this is that we don't have any follow-up on people who have exited the military. In particular, if people have left the military because they're having knee problems, that would create a bias in our study, where all of our effect measures would tend to be a little bit depressed or diminished relative to what they could be, or would be if we had those people. So significance of this project, it's a cohort of young, healthy, physically active people who load their knees a lot in the course of their employment. We are getting good follow-up time on these people, and I think big thing for this project, we invest a lot of money as taxpayers in these people. I think it's good to understand how we can help them maximize the return on that investment through ongoing good joint health. And even after they leave the military, we will continue to pay for these injuries either through private insurance, which eventually is passed on to all of us by our insurers, or else we'll pay through the Veterans Health Administration. I realized I had over 50 slides before I got to the biomechanics, but I'm very happy to come back and talk more about biomarkers. The biomarker analysis is really still a work in progress because it's very complicated to really tease out these differences. And so I'm not going to commit one way or the other, but happy to come back in a few months and do a part 2 if you're willing to put up with more of this stuff. I think it would be good, obviously, to talk about prevention and interventions and things that we can do to help these people, like preventing the initial knee injury and helping them mitigate and understand the risk of OA. And we've sort of been experimenting with a little app, that app as well, as I think all app developers do. I'm going to stop there and open the floor for any questions or comments, because council told me to transition to that at this point in time.
I have a comment, Steve. Thank you. It's nice to see all of this. My comment is we will definitely have you back for the biomarkers because that, was a substantial expense in this project, and it'll be interesting to see, you know, even if it's negative or whatever, I think that's important for us to have those data and see what happens with that. So you can count on us booking you in.
That sounds good. I think there really is something in the biomarker data, but it's taking some work for John and I to, you know, I wish it would have been great to have a lot more information about the conditions under which these biomarkers were acquired, particularly the time of day. So.
Oh, and Steve, there's a question in the chat from Caroline about how many of these participants reported a secondary knee injury or knee surgery.
Yeah, that is a great question. A lot of them have multiple injuries, and we can look at that. And for a while, I was interested in kind of the cumulative burden of injury, particularly distinguishing between the bilaterals and the unilaterals. I think would be something that would be really worth doing. At this point, I'm really focused on trying to tease apart these epochs, where, you know, post 10 years, 5 to 10 within the past 5, because I think that's a kind of an interesting thing in terms of trying to understand the mechanism a little bit better, rather than just the cumulative load of the number of injuries. Is more the timing of the injuries. But I think it would be really interesting to definitely look at multiple injuries, especially, as I say, it would be great to be able to know about the timing between injuries as well, because I suspect 2 injuries close together may be worse than 2 injuries along that are multiple years apart.
I'll jump in with another question. Do you have any data regarding the work positions that the people had? Did people with injuries who have the you know, pain and stiffness and after, you know, within 5 or 10 years, do you think any of their job duties changed so that they became less, you know, strenuous physical activity?
So that is a great question, Lee. And I think the answer to that question is undoubtedly yes, that is true for some of them. But in this culture, obtaining data on that is going to require a special kind of protocol, because to get a really good measurement of that, you're going to have to kind of figure out some good instrumentation where people can disclose that they're having difficulty completing the requirements of their job. And I think there's 2 reasons for that. One, the psychosocial makeup of these individuals is they don't like to disclose if they're not at 100%, that's just their nature. And 2, there's strong institutional forces that discourage them from disclosing that. And this is an environment in which your employer is also your healthcare provider and has your medical record. And sometimes is also your landlord. And sometimes also the employer of your partner, and also owns the daycare that your children go to. So that's not universally true, but you get the picture. So for some people, there was an advantage to participating in the study because they got some information about their needs without their employer having that information. And they perceived that that was a benefit to them. And so I know that because multiple people ask, does this definitely not go in my military record? Does this definitely not go into the military electronic health record prior to signing the consent form?
We have another question and comment from Ellen Schneider. She said, thanks for your presentation, Steve. Apologies if I missed this. to investigate the causes of the knee injuries before and during service?
Oh yeah, that's a great question, Alan. Yeah, I should have included something on there. These are almost all of these injuries occur during sports or military training, and to some extent, military training and sport is a little bit indistinguishable because they're assigned to do intramural sports and things like that. But the training activities involve a lot of running and some agility drills and things like that. So, you know, I think it's running about 1/3 organized sport and about 1/3 or organized or individual sport and about 1/3 training activities. But again, it's the training activities really look a lot like sport, or more so than perhaps it would do if you and I were assigned to do those things. We have people who tour on the gymnastics course, for example, or on the obstacle course. And those are things that probably most of us would not be taking on. And in some cases, they're going into those activities with very little forethought as to what the activity is. So they're sort of told to do the vault, and it's demonstrated a couple of times, but it's not the same level of careful preparation that you would do for a high school or middle school gymnast. So that's been a sticky point with military training.
And I did want to add that we do have an extensive questionnaire from the original JUMP-ACL study that asked about injuries, and there was also some medical record reviews. So some of that information is available.
It is nice to be able to go to one healthcare system in order to verify the self-reported injuries. It's wonderful. There's one big EHR and everyone's in it. Now it's not perfectly complete because it doesn't always capture things that happen in active duty and during combat theater, but or it's not perfect for the ships, for example. But most people are not stationed in those environments, so it is wonderful to be able to have a single unified EHR. Reminds me of New Zealand.
So there's
So
another question, Steve. Do you see it from Becky?
Yeah, I see that Becky is asking, do you have any idea if they continue to participate in these activities, participate in the same rigorous training programs? In other words, do they stay active? So these people, Becky, all stayed active. Now, some of them might have lost the better part of a year from a ACL injury. So they might have been injured, been unable to do their training to the full capacity, and then they might have had to wait some time for reconstruction and then being reconstructed and rehabbed. They tend to be very careful about the timing of that. But they will still be doing stuff even when they're injured, right? So they will have to march with the platoon, but they will march on crutches, for example. So it's insufficient to say there's a stigma here. It's way beyond that. But eventually, after they're reconstructed, they come back to full capacity, and they're expected, and they do perform at the same level. And that is, if the military feels that they're unable to get someone back to 100%, then they start looking at what their options are for that person separating from military service. So these people were in. So all of these people got back to as close to 100% that no one could tell the difference. But as I said, we don't have data on the separations. So it's possible there are some people who never made it back or had comorbidities like early onset cancer or something like that, like one of our subjects did.
Okay, thank you. Because the reason I was asking that is because I was just wondering if this is actually a great population to study what continuing with activity does for people, as opposed to a lot of people get these ACL injuries and they go through rehab and think it's too hard, so they just stop doing any kind of activity anymore. So this seems to me like a great opportunity to study these people who were kind of forced to continue on being active, as compared to people who can just kind of like be like, well, I give up.
35 is a crunch time for most people in the military. It's when things are beginning, you're starting to feel it after 15 years of this. Your body isn't quite the same. And, you know, because it's now 65 for those knees. And so 35 is kind of when people have to make a decision. Do I stick it out for another 5 years, or is it time to think about some sort of a discharge mechanism? So there are definitely people who get out, and there will be people getting out. But this is an interesting group, because if you stay in, you have no choice but to perform, and their weight is carefully scrutinized. You cannot gain a lot of weight and retain this, stay in this occupation. If you experience a lot of weight gain, then you will be put on a remediation plan. And they have, you know, they will body tape you on a regular basis to make sure you get that weight off. So, you know, it's interesting in that regard, not just in that they're forced to stay active, but they're forced to stay active without any substantial gain of body mass. So that's kind of a unique population, I think, because I think most people lose the function and then gain the weight. And this population's forced to, not allowed to do either if they want to keep their job.
Thank you. That's great. Good to know.
Are there
Okay.
any questions? Well, thank you, Steve. As Becky said, it's always interesting to hear about this.
Well, I always appreciate the chance to talk with everyone at Keola. This TARC is a wonderful place, and you guys do great work. It's an honor to be part of the center.
We're glad you're part of it. Thanks so much.
Oh, and I wanted to make sure that we also recognize Kristen Shu, who's a rising fourth year PhD injury epi student who's worked a bit with us on this project. She helped, we have 2 full manuscripts that have been drafted about the OA outcomes as well as the PROs. And so some of the tables that you saw today were ones that Kristen had taken the time to design.
And I think I might have missed my acknowledgement slide. Did I forget to show this one? I'm sorry. Just want to recognize all of these individuals, but totally agree with Yvonne. Kristen has been awesome. And I hereby accord her the degree of PhD to be.
I like that to be.